Okay, good morning, everyone. We're going to go ahead and get started. It's okay, stay in line and get your food and coffee. We're going to have to change the setup next week, and maybe we'll have the food upstairs, so you'll know what to do next week. But this morning, it's my pleasure to introduce Dr. Michael Cripps. He's an associate professor in the Geitz division. His talk today will be coagulopathy in the SICU. He's a native of Texas, did his undergraduate training at New Mexico Highlands University, went to medical school at University of Texas at Houston, and then was trained by several of our faculty and alumni. He did his general surgery training at UCSF East Bay with Dr. Alden Harkin. He did his tax fellowship at UCSF with Dr. Mitch Cohen. He was on faculty at UT Southwest in Parkland for 9 years and recently recruited last summer here. He's been spectacular. I've met with him multiple times and have worked with him on several projects. He's an excellent surgeon and leader, has mentored many residents and fellows, has 70 peer-reviewed publications, and has held numerous grant awards, including from the Department of Defense. He currently serves as the Trauma Medical Director at UCH and Section Chief of Tax. Thank you for giving the talk this morning, Michael.
Sure, my pleasure. All right, so coagulation in the ICU is what we're going to talk about today. So I do some coagulation research, and these are a couple of companies that have paid me to do some of that coagulation research. So today's objectives are to understand the role of coagulation in the critically ill patient, and to understand the association of hypercoagulation and the pathogenesis of disease, and to understand the role of chemoprophylaxis in critically ill patients. And these are all topics that you could have a week-long seminar on any of those topics. So I am well aware that today is going to be a superficial covering of these. And here's what I'd really like for you to know. And that one is, if you have a patient that's in the ICU, understand that they probably have a coagulation disorder. And number two, there's this concept that if you have a patient, fresh post-op patient in the ICU, and you walk by the room and you mention the words Lovenox or heparin, that's somehow going to evoke a scene out of The Shining where blood's just going to start pouring down the hallway. And here's the thing, that's just probably not true. Okay, let me rephrase that. It's definitely not true. So by the end of this morning's talk, that's why I hope the message to get across to y'all. All right, so coagulopathy, start there. So there's a range of disturbances of coagulation pathway. And I use the word pathway in quotation marks because, you know, for the outside, this is what you try to memorize the night before the test. When we have to take the boards, we used to try to memorize it the night before the test. Then we decided we're just going to get that question wrong. But the good news is it doesn't look like that. All right, it looks more like this. And so this is something that Dr. Cohen put together, and this is an interactome between coagulation and inflammation. And it looks more like the flight pattern out of DIA. It really is complicated and complex, and this is probably just the tip of the iceberg. Another way that I talk about this, and I was very happy to see this published by Dr. Moore, is it really is a spectrum. It goes from hypocoagulable to hypercoagulable, and there's a lot of mix in between, and it's all interrelated. So when I talk about the hypocoagulable state, this is when we have those patients are in hemorrhagic shock. Again, a couple weeks ago, you heard I talk about hyperfibrinolysis and that pathway. And so when you have the hyperfibrinolysis, that's the bleeding pathway. You get thrombin depletion and the early death. Now, it's juxtaposed to the hypercoagulable pathway. This is where you have platelet activation, fibrinolytic shutdown. This is where you start to get your VTEs and your multiple organ failure. And it's important to remember that it's all related and it's all a spectrum. I'm a trauma surgeon, so I see the world through the lens of a trauma surgeon. But the fact of the matter is, it's not just related to trauma. As a matter of fact, you can see it in every surgical specialty and in a lot of medical specialties, even the ones that we get called to operate on. And I'll talk about that briefly. Now, one of the residents here, I was very happy to see when Dr. Somlowski published this paper talking about the dynamics of coagulability. So when I first got into this, I really liked those patients who were bleeding to death. How do you transfuse them? How do you resuscitate them? How do you keep them from dying on the table? And the fact of the matter is, whenever that would happen, we save them, we tuck our thumbs in our armpits, walk back like, hey, I saved this person's life. but we tend to forget that that coagulation disturbance is still ongoing. And the beauty of this paper, Samowski showed that 98% of these patients after arrival are either normal or hypercoagulable at 24 hours, with about close to 60% of them being hypercoagulable, and that lasts for some amount of duration afterwards. So that's what I'm going to focus on mostly today, which is the hypercoagulable state. And although we've known about VTE for decades or longer, it's probably underappreciated trauma and acute care surgery. Also, I want to talk about COVID. That's going to be my medical topic for today because it's, relevant. And I'll briefly discuss the hypocoagulable state because it is this part of the spectrum. So the hypocoagulable state shows up in hemorrhagic shock and tissue damage. You can have it with either one of those, but it's really the combination of the two that leads to that acute traumatic coagulopathy. And this is mediated in part by increased endogenous TPA, hypocalcemia, inhibition of factors, the hyperthermolytic, plate dysfunction, and time from injury. And when residents would ask me to talk about, hey, what do you think is the best thing for this hypocoagulable state? Is it TXA? Is it whole blood? What should do? My number one answer is stop the bleeding. All right, that's what we have to do. So now, as you're making that effort to stop the bleeding, what should you do? I like resuscitating with whole blood if we can. At some point that'll run out, then you got to go to component therapy. And then if you have that capability, use your viscoelastic guided resuscitations. Here we have TAG. When I was in Dallas, we used Rotem. And what that does is allows you to identify those components of coagulation that you need to resuscitate. Now, the thing about viscoelastic guided resuscitation, I'll say, is that if you've ever been to OR with a patient bleeding to death, it gets pretty chaotic in there. And everybody's doing everything they can to try to get them resuscitated. We're trying to stop the bleeding. So it is kind of hard to remember to put that tag, order that tag, get it displayed up there. Now, for me, it's a little bit like looking at the matrix. I can look up there and say, that's platelets, that's fibrinogen, that's FFP. But if you haven't looked at 10,000 of them, it can get a little bit tricky. So that's why I say I really like to use them in the ICU, especially when you're coming out of the OR, they're a little bit oozing. Get your tag in a controlled environment, determine what you need to resuscitate, and make your interventions. Okay, that's all I'm going to talk about today for hypocoagulable because I want to focus mostly on the hypercoagulable pathway after that. Why are we still talking about this? Virchow talked about it hundreds of years ago. We're still talking about it today. We've had multiple of these complex case reviews since I've been here, and at least 2 or 3 of them have focused on VTEs and the complications thereof. So it is a very relevant topic too. And we're starting to understand more about the biochemistry and physiology of it. Another thing I think is fascinating is those patients who are very hypocoagulable when they start also tend to be the ones that become most hypercoagulable later on. And there's variable causes, timing, clinical effects, and response to prophylaxis. And VTE is still a major problem. The mortality rate of a PE, depending on what series you look at, can be all the way up to 22%. We also know that hypercoagulable states associated with multiple organ failure and strokes. Okay, again, when we go back to the spectrum here, we look at the hypercoagulable pathway, and we look just one component of this, the fibrinolytic shutdown. Again, this is what Dr. Moore talked about, so I'll just go over this briefly, but one of the things I really loved about this paper is that when this published, we knew that there was hyperfibrinolysis. That's that hypocoagulable hemorrhagic shock death. We knew that there's a physiologic fibrinolysis, and that it took this paper to say, like, well, maybe there's something on the other side of that spectrum too, the hypofibrinolysis, the shutdown component. And when they did, lo and behold, there is. And not only is there a hypofibrinolysis, but there's an associated mortality with that as well. Now, the hyperfibrinolysis, again, that's your bleeding to death. The hypofibrinolysis tends to be your multiple organ failure, your sepsis style deaths. So this prothrombotic looking picture. One of our former fellows here from Denver, Dr. Mysoso, he looked at this when he was a resident in Miami and looked at persistent fibrinolytic shutdown on patients who were admitted to ICU who had a tag on admission, and 7 days later. And what he found was that almost half of those patients had persistent fibrinolytic shutdown. Furthermore, those that did had a significant increase in mortality with an odds ratio of 8.5. They saw the same type of U-shaped curve for that hypofibrinolysis increase in mortality. And we don't just see this in trauma patients. Here's a paper I found in liver transplant where they saw the same thing with hyperfibrinolysis, and an increased associated mortality. And the thing that I really was struck by this paper that I liked a lot was not necessarily the difference in mortality, because it isn't huge, but they kept seeing it for months out afterwards. And I think that's going to be one of the things that comes into play on my last slide. All right, so when I talk about hypercoagulable state in surgical patients, a lot of the responses I get are like, hey, sure, yeah, well, we'll just give them a little bit of prophylaxis and everything's gonna be great. The problem with that is we currently do not know the optimal prophylactic regimen. We do not know the optimal timing of prophylaxis, and we do not know how to appropriately measure hypercoagulable state and correlate that with clinical treatment. So if you want to know where we are and where we're going, you got to know where we've been. So this is Geert's original paper, New England Journal of Medicine, comparing heparin 5,000 units BID to low molecular weight heparin 30 milligrams BID in trauma patients without TBI. And what they found was that in the enoxaparin group, there's a statistically significant decrease rate in DVTs with no difference in bleeding, and thus ushered in the era of 30 milligrams BID low Venox, or low molecular weight heparin for all trauma patients. Now, a few years go by and the group of San Diego is like, man, we are still having quite a few DVTs and PEs in this patient population. So they decided to look at this using the 10A level. Now, the 10A level is essentially a lab measurement that says this is how much 10A you have left over after you've given them the low Venox or the heparin. And we could have a whole nother grand rounds just on the merits of that. But suffice it to say, it's the best tool we have to measure the efficacy of anticoagulants. And when they did this, they found that 70% of their patients on 30 milligrams BID were subprophylactic. So a couple of years later, they increased that dose to a weight-basing dose, and they were able to pretty much flip it. Now, only 20% of their patients were subprophylactic. Now, they did have 5% of their patients being super prophylactic, but there's no bleeding complications. Now, I'm at Parkland at this time, and math is hard for me, so I said, we're just going to do a 40 milligram BID straight dosing for all of our trauma patients. And when we did this, we found, again, just about the same. About 30% of those patients are subprophylactic. Now, the interesting thing I found on this was that if they were subprophylactic, I would increase their dose. But 17% of those patients never reached a prophylactic level. So we went through and we looked at clinical parameters that we thought might affect that, and there were none. No clinical parameter that we identified affected their ability to have a prophylactic response, which means to me there's a clinical variable I didn't measure, which probably not, or more likely there's a biochemical agent at play here that we're not measuring. At that time, when my fellow said, hey, can we do this in the EGS patients? And I said, I don't even know if we have an increased risk in EGS patients. So we did an M.S.C.S study. And when we looked at this, we found that the rate of VTEs is about 2.5 times higher in emergency general surgery patients. Now, of course, it does increase with the level of invasiveness of that type of operation. But on the multivariate analysis, being an emergency general surgery patient statistically significantly increased the risk of having VT. That makes sense. If you look at Mitch's slide early on, inflammation and coagulation are intricately related. We've all been in these emergency general surgery patients, and an emergency colectomy doesn't look anything like an elective colectomy or a ventral hernia repair, even a gallbladder. So we know that there's this is at play here. So in the hypercoagulable state, we know we see it in trauma patients, we see it in emergency general surgery patients, and we also see it in a lot of medical patients too. We often get consulted for patients, medical patients who have significant comorbidities. And I decided to talk about COVID just because it's, pretty relevant currently. And we still get asked to see surgical consults on patients with COVID. The entire nation went through multiple waves of this. Dallas was no different than Denver, and where surgical ICUs got called to come in and help out and care for these patients with the pulmonary disease. And it's very heartwarming for me to see a lot of surgeons across the nation actually led a lot of the research looking into the coagulation disturbance on these folks. And this was recognized actually really pretty early on in these COVID patients when they had the severe thrombotic issues in their lung. I really like this one out of the Netherlands. where it said about 30% of their patients, despite adequate prophylaxis, were still prothrombotic. And that's going to be the crux of what I'm talking here is this definition of adequate prophylaxis is probably incorrect. But nonetheless, the Wuhan group said that if you were hypercoagulable, you had a significant increased risk of death. And pretty much no matter where we looked, every time we turned around on these COVID patients' mortality, hypercoagulability remained as one of those preeminent factors that predicts death. And then this group here too, one of my partners, Frank Wright, led a group looking at about 40-something patients with COVID and found that there was a huge difference in their VTE rate and in their dialysis rate. Again, this microthrombotic complications and the increased risk of VTEs and need for dialysis. So this is where I kind of made that snarky joke at the beginning here about people being very, very afraid of chemical prophylaxis. And I don't want to dismiss it. I'm aware. I know that there are potential cases where that can happen. However, the problem with that fear is that fear leads to a delay in the implementation of adequate chemical prophylaxis. And what you need to do then is go back and look at the data. Is that fear founded or not? Should we wait? Oh, well, they're pretty high risk for bleeding. I think we need to wait a few days. Well, what does the data show? If you go back and look at the early reports of this, it was on that low-hanging fruit. Those solid organ injuries, right? So solid organ injuries, pelvic fractures, and each one of these studies all said the same thing over and over and over again. These solid organ injuries, you can start early chemical prophylaxis. You're not going to increase your risk of bleeding or need for operative intervention. Then somebody came along and said, like, yeah, well, what's a little bleeding among friends in a splenic injury or liver injury, right? Let's look at the stuff where there's really a complication, the neurologic injuries, the TBIs, the spinal cord injuries. So my buddy at Arizona, Bilal Joseph, his group looked at this and a propensity score matched analysis of non-operative blunt spinal trauma and TQIP data comparing early versus late VTE prophylaxis. They define that time frame as 48 hours. Looking at DVT and PE rates, and then for the complications, they looked at laminectomy rates and and blood transfusions. And what they found was that those who had implementation of VTE prophylaxis in less than 48 hours had a very significant decreased risk of VTEs in both DVT and PE. Furthermore, there was no increased risk of laminectomies or blood transfusions in these patients. One of my partners at Parkland, right before I got there, published his analysis called the Delayed versus Early Enoxaparin Prophylaxis Study, where he looked at a pilot study in 62 patients for early versus late chemical prophylaxis in patients with traumatic brain injury. And at that time, we had it stratified out into 3 categories: low, moderate, high risk TBI. And in that low-risk group that had a stable head CT at 24 hours, starting Lovenox 30 milligrams BID, there was no increased progression of intracranial hemorrhage. I got there, I think like 2012, and then started helping Phelan with this project. And so a couple years later, we looked at over 400 patients in a retrospective analysis on patients with intracranial hemorrhage and TBI. Who had, again, we looked at the progression and we looked at timing of VTE prophylaxis initiation. And then this is the end result, which is we're able to take those 3 categories and push those down into 2 categories. And we became very clear on the types of TBI that you had to have in order to fall into this category. So these several categories up here at the top, the small or subdural epidural, no large single contusion, isolated subarachnoid intraventricular hemorrhage. If you fell in that category, and at 24 hours, you had a stable head CT, 30 milligrams Lovenox BID, no risk of progression in TBI. If you're in the high risk group, we waited 72 hours. Repeat that head CT. If that's stable, you could then get your Lovenox 30 milligrams BID. If you weren't, then you had to go into the different category. For whatever reason, serial duplex or IVC filter or something along those lines. And then this culminated, and this is probably like, I don't know, mark 7 or 8 of our Parkland algorithm for VTE prophylaxis. And the thing that we said here is we're going to be very aggressive on implementation. So the first question we asked, can a patient receive low molecular weight heparin in the trauma hall? That meant we asked our question, is this patient going to be admitted? Are they going to be admitted for more than 24 hours? Do they have a neurologic injury or a high-grade solid organ injury? If the answer to that question was no, they got Lovenox, and we used the straight dosing, 40 milligrams BID, and they got their first dose in the trauma hall before they left the ER. That's pretty aggressive. And then we followed their 10A levels. And if they were subprophylactic, then we had another risk adjustment algorithm. Again, I got a whole nother set of talks on the risk adjustment algorithm and IVC filters. But what we said is at that point, if they were subprophylactic, they were not being prophylaxed against VTEs. So we increased their dose and they got an IVC filter. If they were low risk, we just increased the dose. And then we tracked all that data, and that's how we said that there's that certain percentage of population that never reaches prophylaxis. If for whatever reason they could not get Lovenox in the trauma hall, we would wait 24 hours and do a reassessment. If at that point we said, hey, we're good to go, then they entered the other side of the algorithm and we're back to where we were. If not, we said, hey, this person's just high risk because by definition, they can't get chemical prophylaxis. So those patients would get a filter there too. And what we found over the period of 7 years, 8 years that I was working on this was that in this aggressive push of VTE prophylaxis, we were able to decrease the rates of our VTEs, including decreasing the rate of our fatal PEs. We decreased the average time to VTE prophylaxis. We also saw no change in bleeding complications. We also saw no change in the TBI progression. Also, we found that some patients do not reach prophylactic levels, no matter how hard we push. And I would have some patients on 100 milligrams BID of low molecular weight heparin, and their 10A levels would still not hit into that prophylactic range. Now, just about a month ago, the American Association for the Surgery of Trauma and the American College of Surgeons Committee on Trauma published their trauma clinical protocol for inpatient VTE prophylaxis. And WST, COT, a couple of our biggest organizations that help guide some of our protocols. And when this protocol was published, there was a few things that I was very happy to see. One is that they used our, all right, see that box at the top right corner? That's mine and Dr. Phelan's TBI protocol. So they just copied it verbatim, put it in there and said, this is what we should do for traumatic patients with TBI and how we risk adjust them. And then the dosing we use is exactly the same, 30 milligrams BID for that group. They also said, they took from our other paper saying, if they don't have any of those risks for injury, this TBI, spine, or high solid organ injury, that they should start their prophylaxis immediately. This is not admit, wait the next day, see how they do. No, immediately. And then they were smarter than we were, and what they said was, yeah, we see the rate-based dosing, we see the 40 milligram BID dosing. We recommend both, but we'll have a cutoff. So BMI of above 30, use the weight-based less than that, use the 40. And then also, like the rest of us using the 10A levels, they also recommend that. So it's one of those sort of nice things to see after multiple years of banging your head against the wall and getting these papers out there to see it put into a big national algorithm. So this is my last slide. So another thing I will talk about with trauma patients is that whenever we see these patients come in, they're severely injured and then they're hypocoagulable. And then like Dr. Somlowski said, within 24 hours, the majority of them end up back here at the normal coagulation capability, with about 60% of them then progressing up into a hypercoagulable state. For a lot of our EGS patients, my hypothesis is they're probably going to start out here at normal or already in the hypercoagulable state. We get consults for medical patients. Lots of them probably already in this hypercoagulable state. And then we get them here admitted and we say, okay, we're going to initiate our VTE prophylaxis. And when we do that right about here, what we think is happening is this. We think that we put them back down to normal. And again, we stuck our thumbs in our armpits and walk around and said, I did a good job today. And I have prevented this person from getting a VTE, either DVT or PE. But that is probably not what's happening. And I don't have data to support this. I got a bunch of data that supports a hypothesis of this, but I think this is probably what's happening. I think we probably take these patients and take them from a hypercoagulable state, and with initiation of VTE prophylaxis, probably make them a little less hypercoagulable. Now, here's the other part of this that I don't know, but this is what I was talking about on that liver transplant graph where I said you could see these results of this fibrinolytic pathway happening months out. I'm suspicious that this hypercoagulable time frame is also happening for months out. When we look at trauma survivorship data, we see that there is increased risks of mortality, non-trauma related for months and maybe even years afterwards. And there's been all sorts of hypotheses on why this is, and some people put on the critical illness when they're in the ICU and the types of sedation we use and things of that nature, this myopathy of critical illness. I'm probably going to start putting in there that there is a hypercoagulable disease in there as well. But again, this is the sort of, I don't have data to support that, but this is where the focus of my research is going to be for the next few years. So just to conclude, I think it's important to remember that coagulopathy is a spectrum. There's from the bleeding end all the way up to the clotting, from the hypocoagulable to the hypercoagulable. Despite the volumes of research that are out there, I will tell you there's a lot more work to do in this area. And if you have a patient that is bleeding, be aware of that initial resuscitation conduct. Be cognizant of how you're going to do that, whole blood, component blood. Use your viscoelastic testing if it's available to you. Hemorrhage control. Got to have the hemorrhage control or it's not going to make any difference what you transfuse them with. And then after we're done, when you get them in the unit, please be cognizant of the subsequent need for prophylaxis. And with that, I'll thank you. And take any questions.
That was great. Time for a comment or a question? How long does it take to get a 10A? Can you get it in the middle of the night? And why don't we use it more to drive our decision-making process?
Sure, so that's, the answer to the question is technically you can get a 10A whenever you want it, technically. So this is something that whenever I put this into play at Parkland, when we first started doing this, they said we could get a 10A on Tuesdays between 9:30 a.m. and 10 a.m. And that was when we could get our 10A. It's a joke. But the idea is that the lab was really not super excited about doing it. And so what we did is took all the data that we had that's been published out there saying, this is the best data we have to do that. And once you do that, and you just change the paradigm, it becomes like getting any other lab any other time, and you can do it. It's not terribly expensive, and it's really pretty easy to run.
Here we can get it.
Here we can get it, and it is. And I guess last plug is we do have our TACS COG, which is our Clinical Outcomes Governance Group, which is across all the UC Health trauma systems. We have a VTE prophylaxis algorithm. I was very excited when I got here that it's really pretty similar to what we had developed at Parkland and what the COT had just published. There are some areas that it probably could use some bolstering, a little bit more strength to it, and so we'll be working on that too. Yeah, you can get the 10A. You really should be using it. It doesn't have to be just for Lovenox. You can do it for heparin also, and it can give you that sense on where your patient is on the prophylactic scale.
Question, comment? All right, thank you.